Good evening to all the aspirants present here. The debriefing session will be taken by Dr. Neeraj Kumar, sir. So you may take over. Thank you.
Okay. Thank you, Fatma, for introduction. And I think, again, this is a very important domain. And yesterday, I have taken examination of, I think, 3 candidates. All of them performed well, but I think more improvement is required before they appear for the final examination. And today, I will be discussing the important, because it's a debriefing session. So I will be talking about that clinical case scenarios, that what I have given yesterday to the students who were allotted to me. And after each vignette, I will try to discuss the questions also. If you all have any query related to that today's discussion, or meanwhile, if you can ask, if you want to ask any question, you can write your queries in the chat box. I will try to cover it in while we will having a discussion. But the thing is that our aim is to sensitize you all so that you all can go and read these important topics. Okay. So welcome you all. And the domain is your obstetric emergencies. Now, this vignette is about begins like this: that a patient, a healthy having a 28-year-old G2P1 patient admitted to the labor and delivery at 28 weeks of gestation, and the patient complaining of severe headache and blurred vision. And Fatma, are yesterday's students is present or not?
Also, I'll check and let you know.
Okay. So this patient was started complaining of severe headache and then followed by blurred vision. Okay. When in the labor, her blood pressure was 200 by 110 millimeter of mercury with 2+ proteinuria on urine analysis. And then the repeat blood pressure was, again, it was fallen to 160 or 110 with the normal hematocrit, normal platelet count, and normal liver transaminase level. So this is how the case has started. And based on that, the vital signs at that point of recording were 180 by 110 millimeter of mercury. The heart rate was 123. The respiratory rate was 25 breaths per minute, and temperature was 34.2. She was maintaining a normal oxygen saturation on room air. And on doing a quick physical examination, the patient was having no pallor and no icterus. However, the swelling over the hands as well as face were noticed. And in the CNS examination, she was persistently complaining of that she is having a blurring of vision with severe headache, and it is persisting. We quickly obtained a 24 hours urine collection, and it shows a more than 300 milligram of protein. So by this time, I'm very sure that many of you have must diagnose this case. This could be either preeclampsia and few scenarios related to severe preeclampsia. So based on that, my first question was to the students were: define preeclampsia and severe preeclampsia, then enumerate 6 important laboratory investigations that are necessary to assess the severity of the preeclampsia and how she will be delivered, or whether she can be managed conservatively, and what will be the possible causes or potential causes of convulsion in the 3rd trimester or in the puerperium, and what agents should not be used for management of severe hypertension in these preeclamptic patients. So these were my first vignette with 5 questions. Okay? So if we'll talk about one by one, so the definition, many of them have very clearly defined the exact definition, but in the exam, if they will be asking, you have to explain like that there should be a cardinal features for preeclampsia. That should be presence of sustained hypertension, SBP 140, DBP 90, proteinuria more than 300 milligram, protein in 24 hours urine collection. So this is the definition for preeclampsia, but many of them have very well means they answered well. But in severe preeclampsia, what has happened that they haven't able to tell all those things. Like in severe preeclampsia, the SBP should be 160, DBP should be 110, with at least two occasions, 2 hours at least, the blood pressure has to be measured. Many of them has told, not told that part, two occasion at least 2 hour apart. And these were few of the findings that has to be taken care of while you're defining a preeclampsia or severe preeclampsia. So this is a severe preeclampsia, the first question. Now, simultaneously, the next question was asked that what laboratory investigation are necessary to assess the severity of the preeclampsia. Again, the question was already hint was there in that question. So it should start with a CBC. Why CBC? To take care of that platelet count, blood urea nitrogen, serum creatinine, and serum urate. Then few text says that you can go with a serum urate level also, but if you tell BUN and serum creatinine, it will be fine. Then liver function test, you have to explain the bilirubin and transaminase, coagulation profile, blood typing, and antibody screen. Many of the student doesn't use to tell these points: blood typing and grouping as well as antibody screening. So it is one of the important findings that comes in the diagnosis, making a labeling it as a for a severity for preeclampsia. And then last, your 24 hours urine collection. Then after that, I asked that what are the potential causes of convulsion if these patients have a convulsion. So what will be the potential cause? So it means the patient is now landing upon from preeclampsia to eclampsia. So what could be the thought of convulsions? So the convulsions, especially in third trimester of pregnancy or in early puerperium, may be considered eclampsia until proved otherwise. First choice. But other options should be, I think many of the students have told it very right, that hypoglycemia, intracerebral hemorrhage, some focus epileptic seizures like epilepsy, but they forgot to tell about cerebral venous sinus thrombosis. So these are the 5 important causes of that's seizures or convulsions in the third trimester of pregnancy, apart from if you make a diagnosis of eclampsia until prove otherwise. Now, the next question was, what agents and why should be avoided in the management of severe hypertension in the preeclamptic patient? Again, many of the students have told it right, but few of them not able to answer. So if you'll discuss, I like to discuss ACE and ARBs. So these are the two drugs which is contraindicated for the management of, or you can say for the acute management of preeclampsia, secondary to their potential, because why? They can cause neonatal renal failure, and primarily or secondary, they may have a very delayed onset of action. It may take 1 to 4 hours to act. That's why these drugs has to be contraindicated. And then you must be aware of that use of nifedipine, because many of the time you have to use magnesium sulfate, and when you combine this nifedipine with magnesium sulfate, the combined administration may have a exaggerated hypotensive responses. That's why these patients may have a very rapid fall in blood pressure. That has to be avoided. Drugs that is commonly used in this, I've added so that you all can understand that this is the sequence of drug that has to be added for acute control of that blood pressure, which starts with petrolazine, then labetalol, then nicardipine, and then nifedipine. So these will be the choice. But I ask about this first line, that nifedipine, ARB, and ACE. And if yes, why? What is the logical explanation? So one word explanation, that it may lead to delayed onset of action, or the patient may have the child may have a neonatal renal failure later on. So this could be the two findings. The third, the scenario, then the vignette was, after 1 week of preeclampsia, now she started complaining of abdominal pain with some nausea, although the blood pressure has, till at this point of time, blood pressure has normalized, but peripheral blood smear started to show cystocytes like helmet cells and presence of bursae, which you can very easily appreciate in this peripheral blood smear picture. The patient also has an elevated AST, elevated ALT, reduced serum haptoglobulin, elevated serum bilirubin, as well as platelet count was less than 88,000. So at this point of time, now I am sure that almost all of you must be thinking that what I want to ask in this question. So the question was, tell me the first diagnostic criteria. What is the diagnostic criteria for HELP? And how will you enumerate, just enumerate the two classification that is commonly used for the HELP. So many of them able to tell, few of them able to tell the both classification, but few of them have not read that part. So I will discuss this part also. And then my next question, which is very, very common question, the differential diagnosis for HELP syndrome. And then what will be the consequences if you will not manage that HELP syndrome well, what complications that you will get, and how will you manage that HELP syndrome patient? Means all these questions were related to this vignette was dedicated to HELP, and whether any role of systemic steroids in HELP syndrome, or what are the indications of cesarean sections in HELP syndrome. HELP is itself a indication for cesarean section, but what else other would be indications? So the first answer would be there are two classifications. First is your Mississippi classification, and second is your Tennessee classification. So this is diagnostic criteria, and we all know that in Mississippi classification, class 1 showed the maximum severity because the platelet count is less than 50. The AST and LD is maximally elevated, like more than 70. The LDH is more than 600. So these two, like below 2, AST and LDH, this is common in all three classes in Mississippi, right? But only the difference is based on the platelets. So it should be less than 50, 50 to 1 lakh, and 1 lakh to 1 lakh, 1.5 lakhs. So based on these, the severity of Mississippi classification for HELP is there. So class 1 is maximum. Yeah. Hello. Okay. So if you have any question, you just write on the chat box. Otherwise, just listen it carefully. And any doubt, you can write. So Mississippi classification, class 1, maximum severe means severe, moderate severe, mildly severe. Okay, mild, moderate, and severe. And Tennessee classification, it is either true HELP or complete HELP or partial HELP. So true HELP means platelet count less than 1 lakh, AST and LDH almost same that what Mississippi classification says. And in partial or incomplete, there may be severe peak eclampsia with any of these of the following, like the patient may be having a absence of hemolysis, the patient may have a elevated liver functions, may have a low platelet, may have a absence of low platelets. So like that. So at least you should know these two classifications. Now, similarly, the next question was, what will be the differential diagnosis? I think many of the students have able to tell the exact DDs for DIC. So I have asked 5. So 5 is first AFLP, acute hepatitis. So autoimmune thrombocytopenic purpura, TTP, as well as HUS. So almost many of them have told. Few of them added DIC as one of the differential diagnosis, which we will discuss it later, that why it could not be one of the DD. But these 5 are all is 100% classifications for HELP or DD for HELP. Now, complications of HELP. So complications of HELP will start as a battery of complications. We'll start with a DIC. So HELP, DIC is not a differential, it's a complication. And second, pulmonary edema, pleural effusion, ARF, hepatic rupture, hepatic infraction, periportal liver dysfunction, ARDS, and placental abruption. So these would be the complications of the your HELP. Now, how will you manage this HELP syndrome? So conservative management, we all know timing of delivery is very, very important in these groups of patients, and delivery of the fetus as well as placenta is the mainstay. That's why timing is dependent on the severity of the syndrome, whether you are dealing with class 1 HELP, class 2 HELP, or class 3 HELP, and maternal and fetal stability and gestational age of the mother. And treatment should be totally supportive. Your point of delivery is to be managed appropriately in the ICU or SDU settings. And you always considered that delaying the delivery for a period if there is a significant fetal immaturity. So if a fetal is immature, so you can delay these patients. But administration of systemic steroids have shown to reduce the risk of neonatal ARDS or neonatal respiratory distress syndrome. Okay. Now, what is the role of administration of systemic steroids? Now, role is, as per Cochrane database systematic review in 2010, they published, and what they have concluded that use of systemic corticosteroids in HELP syndrome may increase the maternal platelet count, but has not shown any improvement in the progression of the disease or any maternal or infant mortality. So if we talk about the outcome in the form of maternal or infant mortality, it is not so, and there is no improvement in the progression of the disease However, the maternal platelet count has started to increase. So this is one of the important findings that what this Cochrane database showed about the use of systemic steroids in HELP syndrome patient. So I think this answer I couldn't able to get from the students who were appeared for the exam study. Okay. Now coming to the next part, that what will be the criteria for a when you will deliver these patients, if the patient is having HELP, what you will be doing for its delivery. So the fetus should be always monitored through your CTG, that is cardiac topography, and then deliver the fetus once the mother is stable. Vaginal delivery is not contraindicated at all if the cervix is favorable, if the cervix is getting adequate dilatation, and if the HELP syndrome coexists, then you can consider high doses of steroid to uh, for the early lung maturity. And third stage of labor should be managed with at least 5 to 10 units of oxytocin rather than symptometrin or ergometrin, because it will further increase the blood pressure. Now, then what will be the indication? So indication is straight cut. The fetal indication, if the fetus is showing a non-reassuring fetal status, abnormal fetal presentation, less than 30 weeks of gestation. If you calculate the Bishop score is less than 5. If 32 weeks, less than 32 weeks of gestation with some oligohydramnios or some intrauterine growth retardation. If the patient is having a subcapsular liver hematoma, or if the patient is having abruptio placentae. So if you'll see this, the first cause, the first four cause is related to the fetus, and the last two causes related to the maternal. So the subcapsular hematoma and your sustained abruptio placenta. Okay. Now you come to the next vignette. Now this patient was taken inside the OR for cesarean section in view of the indication was abnormal presentation of the fetus. But now what has happened when the when the LSCS was started, the patient was hypoxemic, SpO2 was started to fall, the patient complaining of severity of sweating, severing, as well as cyanosis and bronchospasm. The heart rate was going down like 78, BP was 90/40, heart rate, respiratory rate was 30 minutes, and temperature was, she was also a bit hypothermic. So at this point of time, you must understood that what I want to ask. So here you have in your mind, it has to be there that what will be the probable diagnosis in this case. Okay. So I ask about that, tell me the 5 different risk factors for amniotic fluid embolism in this case, and what is the pathophysiological process for which hypoxia usually develops in AFE. Then I ask that, could you able to give me some of the differential in this parturient patient who is having a profound cardiorespiratory compromise apart from amniotic fluid embolism. And then I ask about DIC score, and then I ask minimum score that is required for a positive DIC, and then what are the various biomarker. I think this is one of the tricky question that I ask. So almost none of the students have able to answer that the current biomarkers which is helpful for the diagnosis of AFE. So I ask at least 3, but they have not able to ask. They will not able to answer. And then I ask about the management of AFE in this patient. So carefully see this answer. The first option is, what are the risk factors? So in this current patient, the risk factor may be a forceful introic contractions, induction of labor. The patient was not very aged, so advanced maternal age could not be one of the choice, one of the risk factor. Maybe cesarean section is a risk factor. The patient was not multipara. The patient was primary gravida. The placenta previa and abruptio placenta was not there in this patient. There may be a chances for cervical laceration, but it was not there. Fetal distress, yes, abnormal presentation of the fetus was there, and the patient few of the patient, if eclamptic, the risk for AFE will increase. So these are the few of the important your risk factors for AFE. Now I ask the second part, what is the pathophysiology? Why these patients have potential to develop hypoxia in AFE? So the factors, if you understand, always these hypoxia are secondary in nature. These are not primary. Why? Because they occurs in combination of ventilation perfusion mismatch, and then few episodes of pulmonary vasospasm, some pulmonary edema, and then leading to left ventricular dysfunction, and finally bronchospasm. So at least these first three are most important cause of development of hypoxia, and this is the last cause why this patient is further land up in hypoxia, especially amniotic fluid embolism. But this is the best answer, that because of the ventilation perfusion mismatch in the lung which has happened, and simultaneously the patient will have a pulmonary vasospasm leading to pulmonary edema, and then the patient will have a bronchospasm. So these will be the probable pathophysiology of hypoxia in AFE patients. Then I asked them, what will the other differential diagnosis which you considered in this patient who is having a profound cardiorespiratory compromise? So the answer would be, first is anaphylaxis. I think no one has talked about the anaphylaxis. Yes, few of them talk about the aspiration. No one has talked about the shock, septic shock. No one has talked about the myocardial infarction. But apart from these four causes, the fifth cause may be the use of your subarachnoid block. Maybe if you started giving a bit higher dose of spinal anesthesia, so it may be going to block your cardiorespiratory fiber, having a cardiorespiratory collapse. Like the patient will have a hypotension as well as bradycardia, and then after that, the patient will have arrest. So the fourth cause may be post-induction hypotension because of the or post-induction subarachnoid block complications. So that could be one of the cause. And but the important four causes are this. Okay. Now I ask, what is the parameters in the DIC score and minimum score required for the positive DIC? So ISTH criteria is very, very much commonly used. So ISTH criteria is, we all know, International Society of Thrombosis and Hemostasis. So based on that, DIC score has been classified. The component are INR, PT prolongation, fibrinogen, D-dimer, and platelets. Okay. But the point is, if you want to rate it as a positive DIC, it should be more than equal to 5. If the patient is having a less than 5 points, so it is non-overt DIC. So this patient is still having a DIC, but it is non-overt DIC. Otherwise, if you'll not manage this patient at this point of time, although it is negative, it could land up in a frank DIC when the problem will be there. That's why you always obtain a coagulation labs values of these lab parameter every 12 to 24 hours if you are able to make a diagnosis for DIC. Okay. So I think you must have to go through this DIC part also, and as per your ISTH scoring. Now, the second part is laboratory finding in acute DIC, that what I already discussed, that the platelet will fall, the fibrinogen will fall, the prolongation in the PT and INR will be there, the APTT will be increasing, the patient will have a cystiocytes and helmet cells. Many of the times, the patient will have a very high D-dimer as well. So these could be one of the lab findings of the acute DIC. Okay. Now, based on that, if you look, if you see that what could be the other problems with these patients. So if we'll talk about this, okay, just wait a minute. Here all once. I think it's not moving. Okay, so the early phase and over DIC concept is there, in which the patient will have a sepsis, deranged platelet and INR, and then these are the findings where you can have a DIC score or early phase DIC and then over DIC, which I have already discussed. Okay, now coming to the next part. Biomarker which aids to the diagnosis of AP. So I got one of the very good article in which they have enumerated few of the biomarkers which has a potential to diagnose the amniotic fluid embolism. So if you'll see, there is activin A. Okay, so activin A, it is relationship that it increases with your gestational age. Then your BNP is the another parameters. Then your CA125, C1 esterase inhibitor, CEA, chromogranin A, endothelins, fetal cell identification, MAT circulation, IGF like insulin like growth factor, binding protein 1, IL-6, pro collagen type 1, N-terminal propeptides. So these are few of the biomarkers that they may ask in your examination. Till now, it has not been asked, but at least you should know that these are the biomarkers that has been tried for diagnosing your amniotic fluid embolism. Okay. Now coming to the next part. So how will you manage these patients? So this patient is early intubation, take care of the airway, 100% oxygen, positive pressure ventilation, large volume of blood, fresh frozen plasma, platelets, fibrinogen, concentrates, cryoprecipitate, and managing DIC. And upon stabilization, you can shift this patient to the ICU. Okay. Now this vignette was again continued, and this now patient was immediately shifted to the obstetric ICU. And on third day ICU admission, her blood pressure got stabilized. Her other vital parameters were also started to improve, and but she started complaining of epigastric pain associated with a few episodes of vomiting, and the patient was having hypoglycemia inside the ICU, especially on the fifth day after ICU admission, with pallor, 1 plus 2 plus icterus, pedal edema, and slight change in the sensorium as well. Now, at this point of time, what diagnosis that is coming in all your mind? So I want to ask the question related to your acute fatty liver of pregnancy, because we are now dealing with a very serious condition, that is AFLP. So I ask straight away that how will you enumerate the pathophysiology and few clinical features? Then what will be the diagnostic features of AFLP, and how will you differentiate this help from AFLP, and what is the basic steps in management, and what will be the first sign of the hepatic recovery? So these were my 4 or 5 different questions that I ask. Now, if we'll see one by one explanation, so what was the problem? So there is problem at 3 level: at placenta level, at circulation level, and then at liver level. Okay. So what will happen? These patients have a defective placental fatty acid oxidation defect. Basically, fatty acid oxidation defect that is in the placenta. So what will happen? The pregnancy induced lipolysis will be there, for which the patient will start forming more and more FFA, that is free fatty acids. So if more and more free fatty acids will be forming, so more and more 3-hydroxyl acyl CoA will be forming, and that's why the chances, because the now this LCHAD enzyme is going to get affected, which is acyl CoA dehydrogenase enzyme. It is the defective enzyme, which what it can do, it can reduce the concentration of acyl CoA. So what will happen if free fatty acids, and this will start, acyl CoA will start accumulating, it will have oxidative stress, it will have a mitochondrial dysfunction, it will have a lipid accumulation, and it can have a lipotoxicity. But this will happen at the level of placenta. But what will happen in the circulation? As these free fatty acids is increased, so this will be going very highly circulating inside the blood. And apart from that, the free fatty acids will be also very much high in the blood, in the circulation. And oxidative stress, because of these oxidative stress enzymes, will be very high. And this antioxidant, which is the physiological response, again it will started to decrease because of the oxidative stress, and because the imbalance between oxidative and nitrosative stress, that's why our antioxidant values will try to decrease. And what will happen when this go into a circulation, ultimately it reaches to the liver, it can cause microvesicular steatosis, and then mitochondrial dysfunction, and then hepatocyte lipoapoptosis. So your cell death at the level of hepatic cells, or hepatic cellular damage, or hepatic cell death will start, which is start from the placental fatty acid oxidation. So I ask that just enumerate me 1 or 2 pathophysiology. The first pathophysiology will be defect in the placental acid oxidation, and the second will be the deficiency in the, or defect in the enzyme acyl CoA dehydrogenase. Okay, so this is the probable your differential. Now coming to the Swenson criteria, which is very much useful for diagnosing your Swenson criteria for AFLP. Now here the question that they used to ask is the values of ammonia. That what is the value of ammonia here? So it would be more than 65 microgram per DL. And what will be the hypoglycemia? So hypoglycemia is around 72 milligram per DL, and then the patient will have vomiting, nausea, abdominal pain, and all, coagulopathy and all. So prothrombin time will also increase. But now, and then microvascular steatosis, which I already discussed in earlier slide. Now I want to highlight here that at least 6 or more criteria is required for the diagnosis of AFLP in the absence of another cause. So it should be 6, at least 6 to be ticked for making a diagnosis. This is what I have asked yesterday for AFLP. Now coming to the same part, that how will you differentiate these patients from HELP? So AFLP and the cell, the patient will have a transaminitis, but the transaminitis will be more severe in AFLP. The hemolytic anemia will be more severe in HELP. The thrombocytopenia will be more severe in HELP. The antithrombin deficiency. Now, this is very, very important. These decreased level of antithrombin 3 are the most common finding in the AFLP. That you have to remember, that this is the only thing where you can differentiate this AFLP from the HELP, apart from the other lab findings as well. There is DIC will be very, very common. Hypoglycemia will be very, very common. Renal insufficiency is more common, and it may range from 20 to 100%, but in HELP it is only 3 to 15%. Okay, so they may ask that just try to differentiate the AFLP from HELP. Now coming to the next question that I asked, that how will you manage this HELP? Management is very, very simple. Like maternal stabilization, first part, so you should focus on the return of expeditious safe delivery. Longer pregnancy, if it is lasting, so risk for development of fulminant hepatic failure will be more. So don't try to increase the length of the pregnancy after making the diagnosis. Expectant management, don't wait for the conservative management. It is not an option at all for the management of AFLP. And you do delivery as soon as possible as the mother condition is improved or stabilized, and there are no reports of AFLP that is resolving prior to delivery. Okay, so till now no reports has been there. Now, similarly, if in pre and postpartum treatment, you should be provide a supportive critical care environment with appropriate monitoring. How will you do that? By taking care of the complications like hypoglycemia, very, very frequent, like coagulopathy, renal failure, almost 100% patients may have a renal failure. The encephalopathy, again, it's a finding which you can see by the raised ICP features, or the ammonia level will be increases by more than 60. The patient will have a diabetes insipidus for which polyuria will be there, and the patient may be having a raised AST, ALT, or serum amylase level also will increase. And then plasmapheresis may be considered as a case where the liver failure continues. So in extreme of the situation, you may opt for orthotopic liver transplantation. Okay, so I have taken this patient for, yeah, and another question was, how will you show that your patient hepatic recovery, initial signs of the hepatic recovery? So the ominous sign, the first important sign, early important sign, is the improvement in the prothrombin time. But if they want to ask some other findings, some other lab values, so you can ask, or you can tell them that, okay, normalization of the liver enzymes is the second, ammonia level normalization is the third, coagulation studies normalization will be the fourth, the serum creatinine, decrease in the serum creatinine will be the fifth, and liver functions typically returns to normal 6 by almost a week or 10 days after the delivery in most of the cases, in approximate 75 to 80% of the patients. Now I asked that what will be the treatment, and now you see this case. Now again, the last vignette, her yellowish discoloration of eye and urine and recurrent non-bilious vomiting was further increased on 7 days after admission, and the patient was afebrile, although now she has started some drowsiness, and icterus and flappy tremors have started to increase. The blood pressure, the pulse rate, the heart rate was almost normal, but the patient was having a leukocytosis, thrombocytopenia, hyperbilirubinemia, transaminitis, and coagulopathy. ABG was normal. No oxidation defect was there. Urine dipstick for protein was negative at this point of time, and no hepatosplenomegaly. So I have asked that what could be the condition that we are dealing with. So we are dealing with here a severe form of AFLP. And then I turned this question for TP. So I want to ask that whether in AFLP, the role of any therapeutic plasma exchange will be there or not. And then I also asked that what will be the various etiological agents that is responsible for AFL, that is responsible for these conditions apart from other than AFLP, and why she is having a persistent organ dysfunction despite emergency cesarean delivery, and what is the role of TTP in the management of above case. Okay, so again, I asked about the role of TP in the work for acute liver failure, few adverse events of TP, few limitations of TP, and then I talked about your DP mass, like your double plasma membrane absorption therapy, as well as therapeutic plasma exchange combination in liver disease. So just see one by one. So if these patient, like if the patient is having a pregnancy in the late part of the patient is having a icterus, so what will be your algorithm? So first, always try to exclude the pre-existing chronic liver disease and portal hypertension. This is most important. You have to rule it out, the portal hypertension and any existing coexisting chronic liver disease. If you have ruled out, then we have to rule out some of the common causes of, like your malaria. You can rule out some common causes of malaria as well. And then after that, if biochemical investigation is indicating that the patient is having acute liver failure, then you see whether the patient is having a thrombocytopenia, elevated LDH with a background of preeclampsia, whether it is there or not. Or if the patient is only presenting with encephalopathy and coagulopathy. So straight cut, if no background preeclampsia is there, you can consider this patient for a AFLP, and then you can give antibiotic, urgent delivery, and prevent hypoglycemia. But if preeclampsia is in background, maybe if preeclampsia is present, you can consider this patient as a help, and then antibiotic, urgent delivery, and prevent hypoglycemia. So the last part, the treatment remains same in both the groups, but the diagnosis is very, very important. That's why the approach should be like that. Okay. Now coming to the next part, the role of your therapeutic plasma exchange. We know that this PEX is plasmapheresis. So what is mean by apheresis? Apheresis means taking away. What you want to take away? You want to remove a large molecular weight substances, like the molecular weight which is having more than 15,000 Daltons molecular weight, like autoantibodies, immune complex, cryo, melanoma light chains, endotoxins, and some lipoproteins as well. Why? Because they have designed, they can remove the substance which has a very long half-life. They can remove the substance which are acutely toxic and resistant to conventional therapy. So it is from Kaplan. And the next part is how this TP looks like. I thought that I should add few part that how these mechanism usually works. So here, what we used to do, that through jugular veins we used to add anticoagulant, and then through a blood pump, a pla- all those plasma separator or plasma OP function will be there, and then through that another plasma pump, the substitution fluid is to be given through this plasma pump, and it will go inside that through a plasma separator again inside that body, and the waste is filtered through a plasma pump. So there is three pump that is working inside that TP machine. One pump that takes that substitution fluid, basically fresh frozen plasma inside the body with a plasma separator, and another blood pump which sucks the blood from the patient vein, and then it goes to a filter, and then it goes inside with the combination of these pump. And then the next part I ask about that what will be the adverse effect. So adverse effects start from the anaphylaxis reactions, anaphylactoid reaction. The patient may present with circumoral numbness, paresthesia of the of the lips or around the all lips. The patient may have a hypotension, the chest pain, hemorrhage, yes, bleeding, the nausea, vomiting, hematoma at the puncture site, infection at the puncture site, and pneumothorax. The other question is that proposed mechanism. What is the mechanism of TP helping in hepatic recovery? So there is it, as we know that they removes important toxic substances, and then they simultaneously supplement the coagulation factors and albumin. That's why one in vitro study showed that this TP induces superoxide SOD activation. They inhibits the malondihyde production. They protect against the oxidative damage as well, and they inhibits the upregulation of caspase 3, which is again a anti-apoptotic or apoptotic marker, and then caspase is 9. So they basically inhibits the upregulation of caspase 3 and caspase 9. What it will do? It will attenuate the hepatocytes apoptosis. So the hepatocytes apoptosis may be started to improve, which is most commonly happens in your acute fatty liver of pregnancy. So this is how the role of TP is. Now, if you'll see that one of the drawback, if you'll combine this TP in liver disease, what will be the major drawback? Major drawback is this TP, unable to remove the substances which are having a that molecular weight of less than 50,000 kilodaltons, and they are very non-selective. That's why they remove the albumin and immunoglobulins as well. And when you'll use DP mass, like double plasma membrane absorption system. So what it will do, it will cut down both these limitations or drawbacks. Like they use a plasma filter to continuously remove the plasma and can remove the medium size and macromolecular toxins without causing significant change in the albumin as well as immunoglobulins. So this is advantage of adding double plasma membrane absorption system. Now coming to the next point. So few of the studies they have done in which what they found that they reported that if you combine DP mass with TP, this significantly improves the survival as well, and as compared to the TP alone. And they also put a similar studies with hemoperfusion or continuous hemodiafiltration. They also found that 90-year survival was more as compared to single monotherapy of TP only. And recent meta-analysis, they concluded that DP mass with TP revealed greater improvement in the bilirubin and INR when TP is combined with DPMS, very lower requirement of FFP. So three advantages there: the bilirubin improvement very fast, the INR improvement very fast, and the quantity of FFP requirement is also very less. And major limitation in these studies is that they predominantly perform in the patient of hepatitis B, leading to acute liver failure or acute on chronic liver failure, and required validation in large cohort. So I thought that these two important aspects is for you all if they ask about TP and DP mass. Now coming to the last next part, because we covered the entire sections. So now I will talk about the loops and your loops and curves. So till this point of time, anyone have any questions? I think you all guys can go and read. It's very, very important topic. You can't skip those topics, okay? And after that, I will be quickly
Just one.
switching. Yeah.
What do you think? Will they ask so comprehensively about the pathophysiology of AFLP or some other disease?
Yeah.
Because there is no timing for that.
Hmm. So yesterday also, I think you were there, Elkhan. So actually, our as a teacher, as a EDIC teacher, our idea is to just test that knowledge. If you tell the pathophysiology for AFLP is related to the fatty acid oxidation defect and the problems in the L chat, like your acyl CoA dehydrogenase enzyme. That's it. This is more than enough for you to answer. Yeah, you got it.
Okay. Yes.
Yeah.
Yes. Okay.
That's why I asked yesterday also to you that, yes, just tell me why this fatty acid oxidation defect. That's why I talked a bit elaborately, and you will get this PPT also for your better understanding. Okay. So now I'm just switching to the next part. I think loops and curve. I'll just take not more. I will take around 10 minutes more for this. So this is is it visible? Slide.
Yes, sir.
Okay, thank you. So then after the completion of that case vignette, I asked few loops and curves, but these loops and curves were only related to the obstetric emergency, because I was thinking that why I couldn't sensitize you all guys for obstetric emergencies, so that if in future any of the question will be there, you all can mark with very confidence and you can fetch 100% marks in that. That's why the 5 loops and curves. The first, the curve, I just have given this diagram, this paper, and I have asked that can you identify that 5 arrows? But the students were trying to struggle. That's why I asked just to name this chart. What is the name of this chart? So many of them has told the chart, but here the most important is this is basically a partograph, but important is to understand this rhythm. So what is this all about? So first information in this partograph, you will see the first is your maternal component. So all those mother information will be there, that what is the name of the mother, what is the gravita of the mother, when the mother has been taken admission. So what will the hospital name, where is that mother situated, like blah blah, like where there's a ward and all. And the second part, then the second arrow, if you'll see, if you'll see this part, I think this is again very important. This part is suggesting of your fetal heart rate. And your fetal heart rate, by seeing those tracings, you can have an idea of this fetal heart rate as well. Just let me remove this. Yes. And I will remove this also. Okay. So this is your fetal well-being. In this, what we can appreciate is your uh, so in this, we can appreciate this small portion like your fetal well-being, where this fetal heart rate. So this is a fetal heart rate. So any variability has been noted or not. And the third part is your labor progress. What is the alert? What is the action? And what is the timing? And what is the hours? So you can see that hours there, 1 hour, 2 hour, 3 hour, 4 hour. And here, if you can see very carefully, it is the dilatation of the cervix. So it is 10 centimeter dilatation. And here the patient is having a phase like alert and action. And the third part is medication. How much medications we have given for that contractions. So here contractions per 10 minutes contractions has been there. And now the maternal monitoring is being noted here. Like what is the maternal blood pressure? What is the maternal temperature? What is the urine as well? But as a examiner, I just want to know whether you all guys understand this chart or not. It's not necessary that you explain all the parts, but at least you can explain, sir, this is a partograph which has a part like which shows a mother information, fetal well-being, some labor progress, and maternal well-being. This is, I think, if you'll tell this, you'll get full marks. Now coming to the next part, next question, I have given this. So again, I have given this chart. I think my annotation is not working. Clear all drawing. Yeah, just wait so that I can explain you in a better way. Don't know, it's not working. Yeah, now it's got. Yeah. Then here, I asked that identify the rhythm, but it was difficult. I know that it is difficult for you all to identify straight. Yeah, straight away. But at least two charts are there. First is your photograph. Second is your cardiac topography. So CTG and Pato. These are the two important graphs that even if they will ask these two only. That's why I thought that I should add important aspects that what is this all about? What is A, B, C, D, and E? So carefully, it's very easy to see the last part, that is E. So it is a uterine tonic contractions. So I can easily appreciate. So based on that, all those graphs are there. How? You just see one by one. So if I will, I think I have so it is uterine contractions, right? And this, after that, the patient is going in a late declaration phase. So now the contraction has a problem. So it's went off in a late declaration is, and now here the variable declaration is there, variable form of declaration. Here the early declaration has started, and then here fetal heart rate acceleration is there, where you can appreciate these fetal movements like variable, early, fetal acceleration, and late declaration. And this is the last part which suggests your uterine contractions. So this is all about your C, T, and G. Cardio topography. At least you can have idea ki the high amplitudes is contractions, the smaller means if you are getting a dipping, if you are getting a big dip, it is always a variable declaration. If you are getting a lesser amount of few dips, it is early declaration, and late declaration, the dips is vanishing. Okay, so it is difficult. So you will not get any dip. But in acceleration, if the heart rate has increased, so you'll get the upstroke. So upstroke means positive. So heart rate is increasing 140, 150, 160. So you'll get an upstroke. So this is an easy way for interpretation, because you have to answer it is in a logically way, and you have to mark it accurate. So I think that it is enough for you all. Okay. Now come to the next part. For better understanding, actually, I thought that for acceleration, so now this is your fetal heart rate. This is your fetal heart rate, right? This entire thing is your fetal heart rate. Now, here the maternal contraction, here the maternal contraction, that is your uterine contraction, and how it is mimicking with the heart rate of the female of the fetus based on the maternal contraction. And here the reassuring sign of fetal well-being is there, because the abrupt increase in the baseline from the heart when the contraction taking a peak, When the uterine contraction taking a peak at any point of time, there is an abrupt increase in the heart rate from the baseline. So this is a reassuring sign in the fetal well-being. But if you want to see, the patient will have a very poor contractions. Now the contraction has started to fade. So what will happen? There is an abrupt decrease in the heart rate from the baseline. So it has started to drop. So what does it mean? It means the more deeper, the more steeper fall is there, it means variable declaration of the fetus heart rate is there. So this is common CTG tracings. This is common CTG trace. And when the patient will have, again, the maternal will start some contractions, like few contractions, but it is not regular. And the onset at the peak of uterine contractions, the heart rate returns to the baseline after the contraction ends. It is basically late declaration phase, which indicate the fetal distress. So you have to understand this CTG monitoring interpretation. So they may ask that what are these three interpretations. Okay. Now come to the next part. So I asked again, the study I asked about this. Okay, what is the modified early warning system chart? So basically it's a chart which is used for the recording the physiological observations of obstetric patients, and then you have to communicate, and then you have to appropriately triage this patient via green pathway, amber pathway, and red pathway. So I have asked that what are the physiological parameters. So many of the students have very carefully seen that values, and then they have answered that correctly, that there is a saturation level, there is a temperature level, there is a blood pressure systolic, blood pressure diastolic, heart rate, and your AVPU scoring as well. So if you'll see that these are the physiological parameters like respiratory rate, like oxygen saturation, any supplemental oxygen therapy is there or not, and then temperature, systolic, heart rate, level of consciousness, pain, discharge, or any proteinuria. But important to understand is if the patient will follow a green scoring, like if the patient will fall in this part, green score, if the patient will fall in orange part, then amber pathway is there, and if the red part is there, so alert is there. So this is how you screen these patients very quickly. So if the respiratory is 12, if the respiratory is 25, you will label both as a Muse score of 3. And like if they give a scenario that the female patients, three category of female patients were admitted to the obstetric labor room. One patient was having a respiratory rate of 12, another patient was respiratory rate of 25 with a temperature of 36, another was having a temperature of 37, and then the patient was having a heart rate of 50 to 60, another heart rate was 100 to 10. So this is how you calculate the scores, by putting the values. Like here it is the score. Like if the score is for all those red, it will go to the red, all those yellow, it will go to the amber pathway. Okay. So this is how you have to understand this modified early obstetric warning system. Now, again, I have asked the important points, that initial management of postpartum hemorrhage, and I think most of them answer it very correctly, except few of them they have missed. So I just want that you have to early recognize the PPH, monitor the vitals and oxygenation. You have to take a very wide bore IV access and then place a urinary catheter, because these patients may be profound risk for having a renal failure, and then obtain a laboratory baseline alert anesthesia, alert blood bank, okay, for activation of your massive transfusion protocol. And then you have to correct hypovolemia and with crystalloids, and central hemodynamic monitoring if indicated. Then you have to correct anemia and coagulation disorders. So basically, if you write that recognition, establishment of IV access, baseline baseline laboratory values, hypovolemia corrections, and hemodynamic monitoring, and then coagulation with blood products, like, I think it's enough, because carefully you have to read that whether they are asking an initial management, or whether they are asking a management of only postpartum. If they are asking a management, then you have to include all those important aspects, okay, like drugs, like surgery techniques, and medical treatments, like that. Okay, now I asked this one of the very, I think, unusual type of question. Basically, give you information that now you don't know whether these EDIC people can be asking the questions related core obstetrics related to obstetric dystocia. So I ask only few important things that what you will do in these patients who are having a shoulder dystocia. So I got a very good diagram or a paper in which you can very easily remember a mnemonic that is B calm or B cam. That is B cam, in which B cam is breathe, do not rush, lower the head of the bed. So you have to lower the head of the bed and then elevate the leg. So if you are elevating the leg, it is Mac Roberts position. So what is Mac Roberts position? You have to do a sharp flexion in the hip. Okay, sharp flexion in the hip, and the patient should lie supine. So this is your Mac Roberts position. What else that you can do? Here you can call pediatrician, anesthesiologist, and nurses, and then you can apply a fundal pressure, that is your suprapubic pressure. How? Downward and laterally to release the anterior shoulder first. So you have to deliver the anterior shoulder first, and then you have to ensure a vaginal delivery. How? By doing an episiotomy, or you can use some extra maneuvers. So what are the maneuvers that you'll use for? So now if anterior shoulder has been delivered, now you try to deliver the posterior shoulder as well. And then if you apply pressure against the baby posterior shoulder, either anteriorly or posteriorly, then it is a Rubin maneuver. I will not tell that these maneuver they are going to ask, but at least you remember this Mac Roberts maneuver. They may ask because this is a very basic maneuver for the management of shoulder dystocia. Rest, I think it's not that easy to remember all those things. But Zanaveli, many of the times they have asked that all these maneuver in EDIC type 1 question, that all these maneuvers has been used for shoulder dystocia, except. So Janaveli, they have given, Gaskin, they have given, Ruben, they have given, Mac Roberts, they have given. So that is how means the things goes on in examination. Okay. So now coming to the 5 best images that I have quoted first. The first image was cardiac arrest in pregnancy in hospital. I think almost everyone has answered it well. They have enumerated very beautifully about that ACLS algorithm. But here, at least I want an answer like high quality CPR, defibrillation on indication, and ACLS intervention, because now I have to analyze the etiology of the cardiac arrest. So I have to perform the maternal intervention, airway, 100% oxygen. Then I have to place a IV above the diaphragm. Then I have to start. This is very, very important that you have to start IV magnesium and stop and give calcium or gluconate. So if receiving IV magnesium and patient underwent a cardiac arrest, so you have to stop that immediately and you have to start giving calcium chloride and gluconate, which I think many of you have not spoke about that. And then you continue the high quality CPR. High quality CPR has to be told. And then defibrillation, the shock, the amount of the joule will be exactly same that what we used to do in adult patients. And then how will you perform the obstetric interventions? Definitely by putting a continual lateral uterine displacement. I think many of you have answered it well. And then you have to detach that fetal monitors. Why? To take that cardiac topography. That's why I have added CTG concept, and then prepare this patient for peri-mortem cesarean delivery. I think if no ROSC is achieved within 5 minutes, 5 minutes is the correct answer if you all guys can answer. Okay. Now the next part is these flare images I have discussed. Okay. Now, based on this, almost everyone has answered that it is a press, and it is a press, and you all diagnose it very well. But we are not sure that how they will twist the question. That's why I have added this diagram for you all for identifying the infracted tissues within press using MRI. So there are 2 forms. One is uncomplicated press in which vasogenic edema will be there. So on T2 flare, the bright on flare and T2. Okay. And if you are doing a diffuse weighted imaging, because they are giving a MRI film, they might give a DWI images of press. So what you will get in DWI or diffuse weighted imaging, the patient will have a hypo or isodense on DWI. It will be never hyperintense. You see how dark the entire area is there. So if diffuse weighted imaging is there, the dark or hypo or isodense area of brain will be seen in press. especially in vasogenic edema status. And if they will not ask ADG, because this is a core radiology in which apparent diffusion coefficient they used to check. But I think these two photos are very, very important, and these two photos are very, very important. Now, the first, if the patient will have a cytotoxic edema, what will happen? The infracted tissues circled in the red will be the area which will look bright on the flare and T2. So this will be the bright area, which is the area which is showing us cytotoxic edema. And here on DWI, if that vasogenic edema transforms to a cytotoxic edema, the hyperintensity will be seen on the DWI, which will be more and more lighter than this. So if you are getting these two images, either this or this, especially you can identify this is a vasogenic edema form of press with a hypointense or isodense DWI, and this is hyperintense DWI, which is showing a cytotoxic edema. Okay, so this is all about from the press point of view for closely looking of these pictures. And apart from that, you can easily identify that occipital area, the parietal areas are going to be have that effect. One more thing I just forgot to tell. So this picture is also known as blooming effect. So blooming effect of the MRI brain in press. How you see how entire brain is blooming, is like just like a flower that blooms. So it is like that. So blooming effect may be seen in press also if you get these images. So these are the images where these are the findings. Here, these are the findings which I already discussed. So intense, hypointense, as well as your hyperintense. Hyperintense on DWI is a cytotoxic edema. Now, the next image was this twin peak sign. I think, again, this is a very common sign for our understanding that in which situation it is found, twin peak sign. So twin peak sign, it is also known as lambda sign. So this lambda sign is found in which situation? So this is dichorionic diamniotic twin pregnancy. So this is one twin, this is another twin. So this is twin pregnancy, and then dichorionic and diamniotic. So if you'll see that amnion and chorion, so both are two in nature. So if you are showing this chorion or amnion, so it is like that. So that's why the two fetus will be there. One fetus is here and one fetus is here. So twin pregnancy, and then this is a chorion. Okay, and this is a dichorion, because here it is another chorion, here this is another chorion. So dichorion and diamniotic, because the fetus here is two amnions, one amnion and another amnion. That's why this patient is having a lambda sign. So you have to remember twin pregnancy. Again, I ask a small question, but again, it was a very important one. This how you looks like. This is a intrauterine death in which you can see the overlapping of the fetal skull bones. These are the fetal skull bones which are overlapping, also known as a Spalding sign in these groups of patients. And this child is going to get is already died inside the womb of the mother, and that's why you are doing ultrasound of the uterus. You will see this finding, which is also known as a Spalding sign. And then apart from that, you can also see that there is a gross distortion in the entire anatomy of the fetus. So fetal anatomy is disturbed, and then you can see, appreciate, these are the few edema, which is soft tissue edema. And these soft tissue edema, if it is more than 5, so it is very, very sensitive for diagnosing your intrauterine death or intrafetal death. So from the next time, if you'll get any of the photos like this, you can straight away differentiate or define that this is a intrauterine death. Okay. Now the next question that I have asked, again, very simple question. Again, it was there. The transvaginal view, how ovary looks like, it is like this. Normal ovarian stroma. So here the follicle with stroma, this is ovarian stroma and this is ovarian follicle, and this is how it is looking like. When you will do a transvaginal view, these follicles are like this. So there are number of follicles. So the follicles is in chains, and this chain is your necklace pattern, which is very, very much frequently found in PCOS. I think many of you have marked it right, but if they want to ask that there is increase in the number of follicles, so though at least you should know that how you diagnose polycystic ovarian disease. So the number of follicles should be more, like it is more. And then your peripheral is string of pearl appearance, which is peripheral distribution, and the ovarian volume is also very, very variable. So these were the questions that I have studied. Yesterday I have asked. Okay. So if you have any question, I'm happy to answer. But my request is you all guys go and please read all those important points, because these questions may be going to ask in your examination. Okay. Anyone who have any doubt?
7 గంటల కన్నా ముందు రాండి.
And I will be sharing the entire material with you all, so no need to worry about the material. But before going to the material, I will just my request is to go and read that obstetric topics. Till now, it is our best effort for you all, so that you all guys mark the questions related to obstetric emergencies in a with full confidence and with full precision, as well as your accuracy need to be there along with in lesser time. You have to be very accurate in lesser time, and don't try to waste your important time in explaining various things. You just be on target, be on points. That's why I have not discussed too many things. Only I have discussed the points that will be very important, because vignettes are like that only. And if you miss one vignette, you will not able to answer other vignettes as well. That's why each reading is very important. Okay. So if no question, so I think all the best from my side. And I hope that you will read it once more, and you'll do best in your exam. Okay. So thank you from my side.